Hi everyone. Last video I've discussed about choledochal cyst in brief. Today we'll solve few questions on choledochal cyst, and this image is for the Todanis classification of choledochal cyst, and it is very important. Now we'll start solving questions. So the first question is, choledochal cyst is an intrahepatic biliary trace. Type 1 is extrahepatic. Type 2 is also extrahepatic. Type 4b is also extrahepatic, and type 1 is intra plus extrahepatic. So the answer is C. Carolase disease is type 5 choledochal cyst. According to Alonso-Ledge classification, which is not used right now, we only use Todanis classification. Type 4b is only extrahepatic dilatation. So B is the correct answer. And true about Todanis modification of Alonso-Ledge classification include all of the following except type 1 is secular dilatation of the CBD. Yes, type 1b is secular. Type 2 is diverticulum of the supraduodenal bile duct. That is also true. Type 4a is choledochal. No, it is choledochal is type 3. So this is a wrong statement. And type 4b is multiple secular dilatations of extrahepatic ducts only. That is also correct. So the correct option is C. Most commonly seen choledochal cyst is type 1. Saccular diverticulum of extrahepatic bile duct in choledochal cyst is classified as type 2. When it comes diverticulum, it is always type 2. Reconstructive surgery for choledochal cyst is not done in. So all types of choledochal cyst need some reconstructive procedure in the form of Roux-en-Y hepaticojejunostomy, or in the form of limited liver resections or liver transplantation. So which does not require is type 3 choledochal, which requires only sphincterotomy. Choledochal cyst resection decreases the incidence of malignancy, but risk persists 80% cases. So that we need to identify the true statement. So in this is a true statement because it reduces the incidence of malignancy, but the risk persists because of the pathogenesis, that is abnormal biliopancreatic junction, which increases the risk of malignancy because there is cystic dilatation of the hepatic tree itself. So 80% cases have stones. This is a wrong statement. Treated by Roux-en-Y cystojejunostomy. It is not cystojejunostomy. It is usually hepaticojejunostomy. That means you add anastomose jejunum to the hepatic confluence. So confluence, that is anastomosing into the right and the confluence of the right and the left hepatic duct. Type 4 is most common. No. Type 1 is most common. So the correct answer is A. Treatment of choice in choledochal cyst is Roux-en-Y hepaticojejunostomy. Yes. So always, if you find the correct option, also try to read all the 4 options. So cystojejunostomy, no, we never anastomose with the cyst. Choledochoduodenostomy, no, there are high chances of stone formation, so we don't do this. And choledochojejunostomy, no, there is high chance of recurrence and stone formation, no. So the correct option is A. And always you should rule out the options rather than arriving at an correct answer, before arriving the correct answer. So 10-year female presents with pain in the right hypochondrium, fever, jaundice, and a palpable mass in the right hypochondrium. So the probable diagnosis is not hepatitis, because they don't present with palpable mass. Usually hepatomas, they come with only palpable mass and there's no fever and jaundice. Choledochal cyst is the correct option. And mucocele of the gallbladder, there is no jaundice in the mucocele of gallbladder. So the correct option is choledochal cyst. So 10 years old female presented with recurrent attacks of cholangitis, CECT done. The diagnosis on the base of CECT is, see here the axial section of the liver is given. So the liver appears to be enlarged, and you can see the saccular dilatations of multiple ducts, multiple intrahepatic ducts involving both right and the lower lobes, and there are few stones which are noted. So this is type 5 choledochal cyst, also known as Caroli's disease. Central dot sign is seen in Caroli's disease. Here only you can see that the duct is dilated with the stone, that is a central dot sign. True about choledochal cyst is, it is always extrahepatic. No, there are intrahepatic variants also. This is wrong. Treatment is cystojejunostomy. No. Excision is the ideal treatment because it reduces the risk of malignancy. Yes. Drainage is the treatment of choice. So only drainage procedure will not resolve the problem until you excise the cyst. So excision is the ideal treatment. Not true regarding choledochal cyst. Epigastric mass, yes, they can present with epigastric and right hypochondric mass. Jaundice, yes. Pain abdomen, yes, due to cholangitis. Cystojejunostomy is the treatment of choice. Nowhere it is cyst. Always remember it is hepaticojejunostomy and excision of the cyst. So this is the correct option. In case of choledochal cyst, bile diversion into small intestine is not done because of the risk of recurrent cholangitis. So bile diversion, this is mainly the duodenum they are talking about. It is because we are anastomosing it to the jejunum. It is also small intestine. They are mainly talking about duodenum here. So malignancy risk, once you excise the cyst, it reduces. And since you are doing Roux-en-Y hepaticojejunostomy, the bile will never come in contact with the main pancreatic duct or the pancreatic secretion. So pancreatitis is not possible. And gallstones, because whenever you are doing hepaticojejunostomy, the patient will undergo cholecystectomy along with the choledochal cyst excision. So this is not the correct option. The correct option is C. So clinical features of choledochal cyst are pain, lump and intermittent jaundice. So whenever there is a duct obstruction, so that results in jaundice. So whenever on treating with antibiotics or giving the drainage procedure, so the jaundice might reduce. So it causes only intermittent jaundice, not a progressive jaundice, because it is not continuously there is no continuous obstruction to the duct. Choledochal cyst develops due to stenosis of the sphincter. No. Dysfunction of the long circular fibers. No. It is usually congenital because of abnormal biliaropancreatic junction, and it's not iatrogenic. Choledochal cyst mostly presents in adulthood. Excision, it usually presents in the adolescent period. So excision is infrequently done. Excision is always done. Presents as a slowly progressive jaundice. No, it is intermittent jaundice. Can lead to carcinoma. It can lead to cholangiocarcinoma. It's a pre-malignant condition. So option D is correct. Not true about choledochal cyst is associated with anomalous junction of the pancreatic and biliary duct. Yes. Type 2 is most common. No, it is type 1. It is type 1. Surgical removal is the treatment of choice. Yes, that's a true statement. If ruptures, it can cause biliary peritonitis. Yes. So the correct option is 9B. Multiple intrahepatic bile duct dilatation with bile lakes and concurrent sepsis is suggestive of, that type 5 is intrahepatic saccular dilatations of the hepatic ducts, so which can cause bile stasis and leading to cholangitis and stone formation. So it is Caroli's disease. All of the following are true about choledochal disease except type 4 is not Caroli's, it is type 5. Type 1 is the most common. Yeah, that is true. And type 3 is also called as choledochal seal, correct. Type 2 is diverticular disease, correct. So the option is A. Choledochal seal is which type of choledochal cyst? Is type B. Type 3. Both intra and extrahepatic choledochal cyst is seen in type 4. Thank you.